Erythema nodosum. It is the most common type of panniculitis. But what is panniculitis? Well, we know that skin has three layers, namely epidermis, dermis, and subcutaneous fat. When inflammation occurs in the deepest fatty layer, it is called panniculitis. So, erythema nodosum is an acute inflammation of the subcutaneous fat producing painful red nodules. It is usually a hypersensitivity reaction where immune system reacts excessively to different triggers. The pathogenesis starts with the immune system receiving a trigger such as bacteria, certain drugs, etc. Instead of reacting normally, the immune cells become overactive. This causes inflammation in the septa, which are the connective tissue partitions within the subcutaneous fat. This is called septal panniculitis. Unlike many other inflammatory skin disorders, vasculitis, that is inflammation of the blood vessels, is absent. Painful nodules develop. There are many causes of erythema nodosum. The most common cause is idiopathic. In many patients, no definitive cause can be identified. Infections like streptococcal pharyngitis, tuberculosis, mycoplasma, Yersinia, histoplasmosis, etc. can cause erythema nodosum. Autoimmune and inflammatory diseases like sarcoidosis, ulcerative colitis, Crohn's disease, rheumatoid arthritis, systemic lupus erythematosus, etc. causes erythema nodosum. Certain drugs can trigger erythema nodosum. These include sulfonamides, penicillins, amoxicillin, phenytoin, cephalosporins, etc. Hormonal and immune changes during pregnancy can also cause erythema nodosum. There are also some rare causes like viral infections, HIV, syphilis, lymphoma, parasitic infections, and other malignancies. Moving to clinical features, it is most common in female than in male with peak incidence between 20 and 30 years. Before the skin lesions appear, many patients develop a prodrome lasting around 3 to 6 days. They may complain of fever, malaise, fatigue, weight loss, cough, and joint pain. The joint pain commonly affects the knees and ankles. After this, the characteristic lesions appear. They are painful, tender, red nodules and are usually symmetrical. The most common site is the anterior aspect of the legs, especially the shins. They may also occur over the ankles or knees. The nodules vary from 1 to 10 centimeters in size. One of the most characteristic features is the change in color. Initially, they are bright red in color, then they become bluish or purplish. Finally, they turn yellowish green, exactly like a healing bruise. This color change is called erythema contusiformis and it is highly suggestive of erythema nodosum. They never ulcerate and heal completely within several weeks without scarring. The diagnosis is mainly clinical. The appearance and location of the nodules are usually enough. Deep skin biopsy is performed for confirmation. It shows septal panniculitis without vasculitis. To understand the underlying cause of erythema nodosum, some investigations are done like complete blood count, ESR, C-reactive protein, throat culture or ASO titer if streptococcal infection is suspected, chest X-ray to look for tuberculosis or sarcoidosis, stool examination if gastrointestinal symptoms are present, and evaluation for inflammatory bowel disease whenever indicated. Coming to treatment, the underlying cause should be treated. Supportive treatment includes rest, leg elevation, and compression bandages if swelling is present. For controlling pain, NSAIDs are used. However, NSAIDs are avoided if erythema nodosum is associated with Crohn's disease because they may worsen the disease. If symptoms persist, other treatment options include potassium iodide, but it is contraindicated in pregnancy. Other drugs include dapsone, hydroxychloroquine, and thalidomide. Tumor necrosis factor alpha inhibitors may be considered. And that wraps up a high-yield overview of erythema nodosum.